Hello friends, now I'll be discussing a topic on urinary diversions. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us. These are very helpful for quick revision and these questions are very commonly asked in the MS-DNB surgery exams, and so it will be helpful for quick revision. Also it will be helpful for NEET aspirants, NEET PG aspirants. So let's get started without further delay. So definition of urinary diversion. So here we do surgery or any procedure to reroute the flow of urine so that the urine is not uh, accumulated in the bladder and causes some problem, to prevent or treat the obstruction to the urinary pathway. So what are the goals of these diversion? It should be non-refluxing so that the upper tract is saved. It should be of low pressure again so that it does not go up, and it should be continent. So when it should not be incontinent, causing discomfort to the patient. Then what are the components? So reservoir, in we have to create a reservoir in which the pressure is, urine is stored at low pressure. So that the upper tract is safe, and then a conduit to conduct the urine. Then we should have a channel so that urine is conducted to it, and then lastly continence mechanism so that it does not become awkward for the patient. Incontinence does not create problem. Then coming to types, the commonly is the temporary one where we have indwelling catheter, which would be pre-urethral, per-urethral or suprapubic. Apart from that, we have ureteric stents and nephrostomy tube. In permanent, we have external diversion and internal diversion. External diversion can be continent and non-continent. Continent could be through cutaneous, and non-continent could be conduits or cutaneous ureterostomy. In internal diversion, we have orthotopic bladder substitution. Diversion to the GIT could be sigmoid or rectum. So these are some of the types of urinary diversion. Then selection of the method. It depends on the age and performance status of the patient, nature of the disease and bowel condition, and lastly the patient preference. Now seeing some of these in detail. So what are continent cutaneous urinary diversion? So first of all, we would see, so as you can see, it is cutaneous in coming to the skin outside and continent. So there will be continents maintained. Now coming to the components. So it will need a reservoir so that has good capacity, low pressure storage, minimal metabolic consequences, catheterizable efferent limb, continence mechanism, non-refluxing mechanism. So these are the components. Non-refluxing mechanism is done through tunneling the ureter. That is the submucosal tunnel of around 4 to 5 centimeter. What are the prerequisites? That the patient should be intelligent, motivated and able to do CIC, that is clean intermittent catheterization, to evacuate the bladder if required. Kidney and hepatic reserve should be there, it should be functioning normally, and bowel should be healthy. Now we'll be seeing some of these types. That is, first is the Indiana pouch, where we use the right colon as the reservoir with imbricated ileum with continential catheterizable efferent limb. So we take out the cecum and the some part of the ascending colon along with ileum, around 10 centimeter of ileum. Appendectomy is done, and the bowel, that is the cecum and the ascending colon, is opened at the antimesenteric border. Then double imbrication of the ileum is done, and ureter is implanted in the pouch that is created from the cecum and the ascending colon, and cutaneous stoma is connected through the ileum. So this was Indiana pouch. Then similarly is the Florida and Miami pouch, which uses cecum, ascending colon and transverse colon, half, one third to half of transverse colon. Then we have Penn pouch, that is cecal pouch with Mitranoff principle, where appendix serves as continence mechanism. So original Mitranoff was where the appendix was transected and button of cecum with a button of cecum preserving the mesoappendix, and the appendix was turned reverse and spatulated appendix was attached to the cecum. Spatulated appendix tip was attached to cecum and the cecal button was brought out as stoma. In modification of the pen pouch, in modification, the appendix is placed in the serosal tunnel and the tip is brought out as stoma. Then coming next is the Meehan's pouch, where the cecal pouch with nipple valve mechanism, and it uses intersuscepted ileal valve to form stoma. Then the non-continent cutaneous diversion, non-continent, so there will be no continence mechanism. For that, it is the ileal conduit. So 10 to 12 centimeter of the ileum is used, and around 20 centimeter proximal to ileocecal junction. Short and straight kink free conduit is made. The continuity of the small bowel and mesentery is established, and ureteroenteric anastomosis is done over a stent, and distal end of the ileal segment fashioned as end ileostomy. So as we can see in the diagram, this part is removed and is made to attach to the skin as stoma, and it is attached to the ureters on the other side. So where there are various ureter implantation methods. What are these? These are Bricker-Nesbitt technique, where end to side technique is used for uretering to attach the ureter to the bowel, and the end is closed. In Wallace technique, both the ureters are spatulated and opened up and laid adjacent, sewn together, and then sewn to the bowel, as you can see in the diagram. Third is the lead hook, where the spatulated length of ureter is introduced inside the bowel into the conduit via the rent and sutured layer wise. And lastly is the tunneled method, where ureter is placed in a tunnel within the bowel wall and fixed. Then we have colonic conduit, for which we use transverse colon or ileocecal region. Sigmoid colon is generally not used if the hypogastric artery have been ligated and rectum is left in situ. So transverse colon and ileocecal regions are used. Jejunum conduit are rarely used. Ileal vesicostomy is done with spatulated ileum with cystostomy fashioned into stoma, done in case of neurogenic bladder. Then gastric conduit, and lastly is the cutaneous ureterostomy, where the end of ureter is brought out directly as stoma. So there could be bilateral ureterostomy, ureterostomy, that is transureterostomy, and double barrel. Now coming to internal diversions. So first in internal diversion is the orthotopic bladder. So orthotopic bladder relies on the rhabdosphincter, normal sphincter of the body for continence, and patient must have adequate function of the external sphincter. Voiding is done by increased intra-abdominal pressure and relaxing the pelvic floor muscles, that is known as the Creed's maneuver. So it is under the control. So prerequisites are GFR should be more than 40 ml per minute. So it should be good renal functioning, intact functional sphincter, external sphincter, adequate bowel length, willingness to perform CIEC if required. Then what are the features of these bladder reservoir? So adequate volume to allow for reasonable voiding interval, that is around 500 ml. Maintenance of low pressure after filling, so it should not be high pressure causing discomfort to the patient or again urge incontinence. Bowel segment should be completely detubularized and reconstructed into spherical shape through the ileum and ileocolon. An anti-reflux mechanism to conserve the upper tract should be maintained. In ileal reservoir, we use 60 to 70 centimeter of the terminal ileum and various pouches, that is the Hartmann W pouch, Studder, Carney Koch T pouch, and Padua pouch are used, formed and used for ileal reservoir. Then coming to colon and ileocolic pouches, orthotopic Meehan's pouch, right colon pouch, and sigmoid pouch. These are some of the pouches made from the colon and ileocolon. Then coming to ureterosigmoidostomy, which is the oldest form, and here the urine is diverted into the sigmoid colon through the ureter attached to the sigmoid colon. Only prerequisite is the anal sphincter should be completed, and it should be able to hold at least 200 ml of fluid in the rectum. Disadvantage is renal tract is exposed to infection from the feces, and we have to maintain the minimized by the constructing an anti-reflux mechanism. This infection passage to the renal tract is minimized by anti-reflux mechanism. And how is that made? That is Mayans to cul-de-sac ureterosigmoidostomy. So what is done here? We create a low pressure reservoir in the sigmoid that is seen in the diagram, on which the ureter is implanted, and the so urine is passed from here, and the bowel contents are passed directly from the descending colon to the rectum. So this is Mayans cul-de-sac ureterosigmoidostomy. So this was about the types and details of the urinary diversion. Now we'll see about the complications of these diversion in short. So first of all, most commonly is the metabolic complication. So electrolyte abnormality, and this depends on type of bowel segment used and the renal reserve present. In case of stomach, there will be hypochloremic metabolic alkalosis. In case of jejunum, it will be hyponatremic hyperkalemic metabolic acidosis. And lastly, ileum or colon, which is most important and must be remembered, that it is hyperchloremic metabolic acidosis with hypokalemia. The metabolic component, there is hyperammonemia, which causes coma in patient with poor hepatic reserve. And in case of renal reserve, it causes increased aldosterone, increased renin-angiotensin, causing hypocalcemia. Then next is the altered sensorium due to magnesium deficiency, ammonium metabolism abnormality, and electrolyte disturbances. Then abnormal drug absorption, osteomalacia, renal rickets due to acidosis and vitamin D resistance. Impacts on growth and development due to above factors. Next is infection, that is bacteria and sepsis. Stones could be formed, calcium, magnesium, ammonium phosphate stone, especially in the patient with hyperchloremic metabolic acidosis with infection. Then comes the effect on the intestinal motility and short bowel and nutritional issue. There could be chances of vitamin B12 deficiency, malabsorption of bile salt, leading to poor enterohepatic circulation causing fat malabsorption. Then malabsorption of calcium and folic acid. These are some of the intestinal disorders, issues that is faced. In cancer, adenocarcinoma, polyp, sarcoma, TCC in the ureterosigmoidostomy, colon conduit, bladder augmentation, and rectal bladder. And lastly is the stomal complication, that could be necrosis, prolapse, hernia, pouching problems, and stenosis or stricture. So this was all about urinary diversion types and complication of them. Hope it was helpful, and if you have liked the video, please like, share, and subscribe. And thank you for watching. Keep studying, keep growing, because knowledge is power. And never give up, because great things take time. See you in the next video soon. Thank you.